Good morning. As we are coming close towards the end of the SOHO in Houston, September 2015, I had the great pleasure of having my esteemed colleagues in CML to talk about the best of CML session today. Welcome Dr. Tim Hughes, he's from Australia, and my friend Dr. Elias Jabbour from MD Anderson.
Thank you.
So you had a great session this morning. And Dr. Hughes, you were the co-chair, and Dr. Jabbour was in the audience, and we had a very lively debate as well. And this best of SOHO is essentially to put things into perspective, all the presentations that have happened this morning, so that the important questions that the community oncologists are asking when faced with a patient with CML. Perhaps you could start with the newly diagnosed CML, and we have been talking about this for so many years, and you saw the presentation from Dr. Saglio this morning, and what are the few takeaway points from that presentation?
Well, the story hasn't changed much over the last couple of years, really, that the data looks very good for the second generation drugs as frontline therapy. We're getting deep responses, they're being sustained, we're getting more and more patients with deep responses, but that's not translating into improvements in survival. So I think that still leaves us with a pretty open question about what is the best drug to use frontline. And I spoke about that, and Elias spoke about that as well on one of the earlier sessions. And I think that the general consensus is that we should be looking to use the second generation drugs in patients who have more aggressive disease. So the high SOHO type patient is where there might be a clear advantage to using a second generation drug. And my own opinion would be also in those patients where we regard treatment-free remission as a very high priority. I think in those settings, there's a reasonable argument to use a second generation drug. Having said that, I think all three drugs, imatinib, nilotinib, dasatinib, have a case that can be made in the frontline setting.
So Tim, you had a great presentation about how we can identify players for the second generation tyrosine kinase inhibitors in the front line. You clearly and elegantly mentioned the safety concern. I mean, the benefit we induce with the deeper responses, they are counterbalanced with safety concern. So for somebody in a community for the next year, what to expect beyond SOCOL and UTOS and Euro score, what's close to become ready for the use?
Well, you know, we have a whole lot of biomarkers coming along, but the challenge there is it's fairly easy to find a biomarker and get some, interesting differences in outcome of the different groups. But to actually validate that's quite a challenge. And I think our problem has been that we're all doing it in a sort of boutique way in small centres, and we really need to be putting our efforts together and saying, okay, here are 5 or 6 really promising biomarkers. Let's study this in the next 500 or next 1,000 patients and really come down to some consensus about what actually allows you to say, here's a patient who's very safe and you can relax. Here's a high-risk patient.
In an era of generics coming next year, and everybody talk about pricing of the drugs and all these concerns. So you think, and you mentioned, and everybody in the room, like the early molecular response is one of the major milestones. Shall we go into an era of induction therapy with the best TKI we have, and then go for a maintenance strategy, sequential combination rather than just having?
Yeah, there's increasing interest in this concept of induction therapy followed by a maintenance with a cheap, safe drug. I guess my concern with that is it's kind of losing the focus on treatment-free remission, which is still my primary focus. And I think you might lose the opportunity in many patients to get them to a point of stopping in a reasonable number of years by going to a more, to a less potent drug. But these are things we need to answer in clinical trials.
Well, we will discuss Swami as well the stopping therapy or not. But here my question I have, if there's 2 ways to go, you can either go with the best TKI, you have a front line for induction, and then lower the dose later on, maintain them with imatinib, and you can stop eventually therapy. Or you can say, well, I have 70% who will do so well with any drug, so I will go with imatinib first, and then at 3 months, I will switch. So if you have to pick a strategy, which one the strategy you will pick?
Well, we picked the latter strategy in the TIDAL-2 study, where we started with a higher dose of imatinib, and then very, very early on, if we thought there was patients who weren't absolutely optimal, we switched them to nilotinib. And I think that's been a very good approach. The question is, would you do just as well going the other way around? No one's done it yet, so we don't have an answer.
And you mentioned the high dose imatinib. I know that the drug will become generic, and let's say it's way cheaper, and so we know from your data and from our data that it's as good as second-gen TKI eventually. You think we'll see more room for higher dose imatinib in the coming future?
That's an interesting question, one I hadn't really thought about, but I think from the point of view of cost, it might become quite attractive. I guess there's still that sort of, the toxicity issues with the high dose imatinib are not minor.
Sure, yeah. It's a great point. I think those are very good questions, I guess, to, in some way, I think the final presentation that you had, where you had this graph about toxicity versus biology, the host versus the CML genome, if you will. I think there are a lot of questions as we're evolving towards that. But I wanted to ask you a question, both of you, and Eli, you can jump in right away. From some of the other presentations from Dr. Saglio, and also in trying to evaluate these patients all the way up to 12 months. And one of the questions for the physicians in the community is the frequency of testing. You saw Dr. Deininger mention the JOP paper saying that all of them know about the guidelines, but only half of them do it. So we have patient adherence, but we also have physician adherence issues.
You know, I can tell you in my hospital and at MD in the USA, and what Michael has said, this is not only data from the community setting, it's from academia as well. CML is a rare disease, and people think, well, we heard about TKI, it's simple, it's easy, you get the drug and they go home and they're cured. In fact, the devil's in the details. They are cured and they do well if you do so well in monitoring. If you see one CML patient every other month, you're not going to master the disease and you have to treat it very well. I think these patients still should be referred to somebody with interest in CML and try to get them monitored very well. And that is important for the doctor. We've seen cases where they refer to us because they have insomnia and they are intolerant. So Dr. Cortez clearly mentioned, do not rush to stop therapy because you have quote-unquote intolerance. So definitely the doctors need to be educated and they need to have more expertise, and these doctors with expertise with the patients. And then involve the patients. Your future is in your hand. If you have a great control, you have to get good monitoring. I always give the example. You cannot win the lottery if you don't buy the ticket. You cannot get the best response and make sure you're doing so well if you don't do a good monitoring. And that is a disaster in the US, especially as well because CML is managed by the community, which is not the case in Europe, in Australia, where they are essentially more academician. And that is our problem. So I think these patients should be seen by somebody with expertise, and patients should be more accountable. And it's a team effort involving patient, mid-level providers, and physician for the best interest of the patients.
Absolutely.
Yeah, I mean, I don't understand the issue, why it's so hard to do a test once every 3 months in a patient with leukemia. I mean, that doesn't seem to be very difficult. But obviously there are structures in some countries where that's quite difficult to do. So we have to understand that better, and maybe it takes a different sort of research to work that out, because to me it's a simple process. Do the test every 3 months, you'll know how the patient's going. Not only will you know what the biology's like, you know what the compliance is like, and that's a really important issue.
It's a good point. I think we have to go back and re-emphasize these points as Eli said, about trying to at least follow the guidelines when somebody who's treated CML for a long time. One other practical issue is the bone marrow, and you talked about so-called scoring, and we also heard about the 3q26 and the additional cytogenetic abnormalities. What are your takes so that they know the guidelines? You can easily do a PCR, even for those who are doing it, but in terms of bone marrows, we didn't really address that as a question, but for more of a practical consideration.
Yeah, I mean, I think we've done away with bone marrows in people to follow their progress once they achieve a deep response. There's no point doing a bone marrow unless there's some hint there might be myelodysplastic or something that becomes cytopenic. The only time I think that you must do a bone marrow is at the start of therapy, where you need to identify, make sure that they're in chronic phase. You don't know that for sure until you do the bone marrow. And secondly, make sure that you know what their chromosome abnormalities are, because that can be a very important factor in their management.
Well, we agree completely in the USA. Bone marrow at diagnosis is a must. The difference we have is throughout the follow-up, and they say in guidelines, they say either PCR or bone marrow, but we don't have international scale in the USA. So by default, so you have to get a bone marrow done. If you don't have a good PCR, you have no way to know what's going on, so you rely on bone marrows, although we don't do it frequently, very rarely, unless you have somebody with chromosome abnormality, you're suspecting something going on, you go after a bone marrow.
Again, I think we see some differences in the way the practices in the US and the rest of the world.
So just to clarify, but at MD Anderson you do have international standard?
We don't. So we have the conversion factor. When we publish and we report our data, we do it ourselves. But when you get a PCR done in a lab and given to a patient, it's not international scale.
So patients that you're seeing are not having their PCR done in other laboratories, is that what you're saying?
Well, even that, if it's done in our laboratory, we don't report international scale. Our conversion factor is 0.37.
Well, you can make the conversion if you wish.
We do it ourselves, correct.
The reason I ask you these leading questions is you saw the debate on the big question for the patients is that you have all these wonderful TKIs, and at some point that they want to ask this question, when do I stop this? There are patients who are taking it for 15 years. So, and you saw the debate on, is it worthwhile stopping this, or is it should be on a clinical study or off a clinical study? And we already addressed some of the points. What are your thoughts on the debate?
Well, I think we're going to differ on this question. I've been saying for the last year that we have enough data now. In the appropriate setting, I think it's a safe thing to do. And that appropriate setting has to be, obviously, to have good quality PCR assay available and to have the appropriate follow-up for the patients. You can't just neglect your patients and find out 12 months later that they've gone into hematological relapse. So if you have the appropriate setup in your own clinical setting, then I think it's a very appropriate thing to do. But having said that, I recognise there's going to be lots of clinicians out there that don't have the appropriate setting and are still going to do it. So I can't control that fact. But I think we shouldn't use that as an excuse. I think there are hundreds, perhaps thousands of patients out there today who are actually taking their drug and don't actually need it anymore. If they stop their drug, there'd be no difference in their molecular response long term. So I think it becomes incumbent on us to identify those patients and to get them off drug. And if our PCR monitoring is inadequate, let's fix that rather than say we have to keep patients on drug forever.
So that will bring me to a very important question. Today in 2016 or 15, what are the strongest factors that can tell you these patients will not relapse? So if I want to pick, I mean, will be treatment free?
I think that the most important thing is duration of TKI. If you've got a patient who's had more than 8 years of drug and they're in a deep response, I think you can be pretty confident it's a very reasonable thing to try. I would not be trying outside of a clinical trial anyone less than 5 years of TKI therapy. I think that's highly experimental. We don't have much data on that, and it could be dangerous.
Well, the EUROSKI data is not for 5 years of remission. I mean, you can be a shorter period of time.
Absolutely, and it's a study.
Correct.
But we have very little data coming through from that and in those sort of patients. If you use the median age in EUROSKI is 8 years, the median duration of TKI therapy is 8 years. Correct. So the number of patients who've had less than 2 or 3 years of drug is extremely dangerous. Extremely, and so I think paying too much attention to the molecular response and saying, oh, this patient's got a very deep response, we can stop, is really inappropriate. You need to think about the duration of therapy.
Have you done, in your study, I know you presented and you're leading the halving time of the PCR. So just I'm trying to, if you have somebody at the beginning, like, he's a young patient, he is a low SOHO or intermediate or whatever it is, and you have a very rapid decrease of the PCR, will that give you an idea of his long-term outcome? Essentially hitting the CMR, stopping therapy and be cured. So when I see somebody in the clinic from day 0, I can tell him you're going to have the brightest future from the disease point of view. Yeah.
Well, the slope in the first 3 months is amazingly predictive for the achievement of deeper response later on. I mean, Sue Bramford's got lovely data on that, which she plans to publish, but it doesn't actually help you to predict whether you can stop drug. That's still an unknown question.
Well, in the US, we love the concept of stopping therapy and save money and then be cured. Still, my concern is, again, maybe not excusable, but we don't have the follow-up needed. Patient will not, the compliance issue with having regular PCR, whether you can educate them or not, we'll try. We had several trials that Jorge Cortez is leading to combine therapy like omastaxine, 5-azacitidine plus TKI to hit the stem cell. What was presented today, we failed to accrue patients miserably, and that is
that's
at
not
the national
surprising
level.
Because patients at that stage, they might take the leap of stopping their drug, but to take the leap of taking an extra toxic drug,
injection.
That's a very different question, and it doesn't surprise me that
Beg
you struggle.
interferon then.
That's a bit more attractive, but only a bit more.
But if I may actually have you persist on that thought, so obviously patients who do well, and we can always look at the setup that helps navigate the patient better. But in terms of those patients who do eventually have a failure from therapy, from the first generation, second generation TKI, from Dr. Cortez's presentation, and also from Dr. Bhatia's presentation. From the biology, what are your 2 or 3 points that you think that came out of today's presentations?
Well, I think we're still struggling to know what to do with the patient who fails several TKIs. I mean, we have fantastic data with Panetta. It's a really effective drug, but the toxicity is quite alarming. And so you have this real dilemma, you know, do you subject a patient to Panetta with all the risks involved in that? And many of the patients you consider for Panetta have already got risk factors for vascular disease, so it becomes a real dilemma. And so increasingly we're looking at using lower doses of Panetta in that setting, but we don't have a lot of data to reassure us, A, that it's less toxic, and B, that it's equally efficacious. So I think we have problems.
But something interesting you presented, Tim, today, the ABL001. And then the way it binds to the drug, it's different than other TKIs available, but still it doesn't overcome all mutations.
No, it doesn't.
And then you may see new mutations, and you suggested that maybe we have to go for a combination with nilotinib or imatinib or dasatinib and have side effects as well to buy. So where are we with the TKIs? Are we done, or we need something else? Ponatinib, ABL101 or something else?
I have my doubts that Panetta will ever become like a frontline drug. I just find it hard to believe we can find a dose that fulfills our needs in terms of intensity and safety. It may be, but it's hard to imagine. My expectation, my hope is that in the patients who really need intensive kinase inhibition, and those are the patients with high-risk disease, that we can get there by using a combination of a TKI and a drug like Ablwoone, maybe Ablwoone, maybe there are better ones around the corner, that can get you that complete kinase inhibition without giving you an extra hit of toxicity.
And clearly it appears that, I think it's not that, going back to the practicing physician, it's not that they don't want to do it, it's just that the education piece. And here, at least in the US, we've seen Elias gone out and done all these presentations about the mutations, so the awareness level goes up. And I guess one of the things is the key is the education on what would be the likely scenario for patients who have the response, and the likely scenario of stopping, what are the requirements for that, and patients who do have the failure, you know, what are the scenarios, what are the possibilities. So I think constant education and messaging is very likely to, you know, improve the adherence to treatment as well.
Very important.
And having said that, you mentioned about PEG interferon, and the reason is we've always, Dr. Jorge Cortes made this, have the disease without the pill, or have the pill and have no disease. So cure with a cure, cure without a cure. So
well, I mean, the word cure, I don't think the patient's not so much focused on cure. He's focused on having a control of his disease and not requiring a drug. I mean, what could be better than that? Does he need the item cure over that as well? I don't know. I mean, a patient with AML, when do you say to them after they've had their induction consolidation, when are they cured? We don't know. We keep on saying to them, well, it's looking better, but one day it might relapse. So I don't think we need to be focusing on giving a patient this label of cure. I think we need to be focusing on making sure the disease is under control, and we can be confident about that if the molecular response is low and stable, ideally negative, but certainly low and stable, and they're not requiring a drug. I think that's a fantastic outcome for the patient.
Any thoughts? And we, especially in the era of PEG interferon, at least the long-term follow-up that you've seen in Anderson, and patients who have the interferon and TKI, and they're off the TKI for whatever reason, and they seem to have no disease. And
well, from the STEAM trial and all the trials, PEG interferon before or after did not matter much for the cure. It's hard to say. So the one question is somebody asked the pregnancy.
Very important question. I think biological question. You have a patient 24 years old, and coming back to the debate, and what advice you would give them? Well,
I mean, the ideal circumstance would be to get them to treatment-free remission, because then it's a very straightforward course, much as it can be having a child, for that family. But if you're forced in the situation where you just can't get, you know, let's say the patient's in their mid-30s and they've got a response, but not a great response, we would often look to using a second-generation drug to try and get that deep response, so that they can actually stop in a safe and stable way. If you have to stop in the patient who's not under good control, then yes, it can be done, and in most cases it's safe, but you are taking some risk. If the disease is still substantial there for 9 or 12 months, that has to be increasing the clonal progression of the disease to some extent. So I think that does provide some risk, which some people are willing to take, of course, but if I can, I'd like to do that in the context of TFR.
You know, I had a patient who I've seen this week. He's 36-year-old and planning to get married, diagnosed with CML, and started on dasatinib as a frontline therapy. And his question is, shall I hold therapy, wait till I get married and my wife gets pregnant? So the question of male and female. So for male, I think we're more in a safe zone, more comfortable to get his partner pregnant.
Certainly now with imatinib, I just haven't seen any data with dasatinib and nilotinib, so it's hard to give them total reassurance. Yeah. But I suspect it's probably okay, but we don't actually know. We don't have the data.
So it's fair to say, no, even the question of stopping, particularly the biological question in pregnancy, highly vigilant patient and a rather highly vigilant doctor and a well-informed patient would be reasonable option.
Yes.
So finally, a question on transplant, and the number of transplants obviously have come down dramatically. And what still are the scenarios that you're seeing in Anderson and Australia that you see patients going into transplant?
You know, at Anderson, in chronic phase patients, you at least try 2 TKIs, if not more. Absolutely. And then if you hit a good response early on, as Jerry mentioned, then you're fine. If you don't hit a good response with an early milestone, then you have to move rapidly. It's not like your frontline therapy, wait 2 years. Early response are reported in the frontline. They are more important in second line or third line because of different biology of the disease. So usually we try 2 to 3 TKIs, ponatinib included. If you have a good response, we keep you on TKI. If not, we go for transplantation. For advanced stage disease, AP, for example, frontline, we do not do transplant unless you don't respond well to TKI. If you transform from a chronic phase, especially with the high blast percentage, then yes, we go for transplant at transformation. For blast phase or de novo progression, we go for transplant as standard of care. When we use combination of chemotherapy plus TKI, we elect to have ponatinib more than that.
Yeah, I guess one of the big questions that we have today is, should any patient in chronic phase go to transplant if they haven't had an opportunity to have ponatinib, because we know the responses are so good. And generally I'd be reluctant to do that unless they had such a bad risk profile. It's hard to imagine they'd be a good candidate for transplant either. So I think in almost every case you'd want to give them a trial of ponatinib.
You know, in the community, it's funny because when the drug was suspended, I've heard doctors saying, well, I prefer transplant. Transplant is safer than ponatinib.
Wow, big statement.
Any final thoughts, Dr. Hughes?
I think it's an exciting time in CML. We have increasing understanding and appreciation of the importance of treatment-free remission. We have exciting new developments. I think Ablwoone is a very exciting new development that will perhaps change the way that we look at frontline therapy over the next few years. So it's going to be exciting.
Excellent. With that summary, I think we'll stop here. Thank you for your time. Thank you, gentlemen.
Thank you very much.
Thanks a lot.